Good evening, ladies and gentlemen, and welcome to the Suffolk, Virginia chapter of the Links Incorporated second webinar in a series of 4 planned to create awareness of cancers. Can we please put our hands together and give Mr. Wesley Wilkins a round of applause, a virtual round of applause. Wesley, can you please turn on your video so we can view you, please? There we go. Okay, he is a 17-year-old junior where he is enrolled at Lakeland High School, and he has also been enrolled in the Jubal Arts program for 10 years at East End Baptist Church. He plays the piano and the saxophone. His instructor is Miss LaToy Albritton. And his proud mother, I'm sure she's on with us, her name is Andrea Wilkins. He was invited by Link Deborah Austin, who is the chair of our arts facet. Thank you so much, Wesley, for entertaining us this evening. Another round.
Thank you.
Thank you. We have planned a very detailed and impressive slate of events for you this evening that is sure to educate and enlighten. Our focus this evening is taking care of you for us. What we need to know about prostate cancer and how to support those we love. Statistics show that prostate cancer is the second leading cause of cancer deaths in men in the United States. It is the most common cancer among men, with the exception of skin cancer, with about 60% of the cases diagnosed in men over 65. We are very fortunate to have Dr. Bradley Carthon, Chief of Hematology Oncology at Emory Winship Midtown, Atlanta, Georgia, as our guest presenter this evening. He will be introduced properly a little later on in the webinar. We will also hear a caregiver's perspective of coping with the physical, emotional, social, and financial effects of cancer and its treatment from a husband and wife team. We are delighted to have our Connecting Links join us this evening, along with the brothers of Epsilon Iota Lambda, chapter of Alpha Phi Alpha, and Alpha Iota, chapter of Omega Psi Phi Fraternity. Their guest, Jubal Arts parents, and parents and staff of Booker T. Washington and Westside Elementary. We welcome and thank you for your attendance this evening. Special thanks to the Information and Communication Committee, Co-Chair of Technology, Link Vera Campbell, Arts Facet, Link Deborah Austin, Chair, Services to Youth, Facet, Link Julia Liggins, Chair, Health and Human Services Facet, yours truly, Dr. Gloria Spruill, Chair, for the assistance in planning this webinar. Finally, and most importantly, our umbrella chair, Link Jackie Chavis, who is the glue that holds us all together. And now I present to you Link Pamela Jones Wofford, who is our Cancer Awareness Designee for Health and Human Services Facet and our moderator for the webinar.
Good evening, everyone. We are so happy that you decided to join us this evening for our prostate cancer webinar. This is our second webinar that we have completed on cancer awareness, as we feel that cancer right now does not discriminate, and definitely not within the African American race. Prostate cancer actually takes a harsher toll on African American men. So we felt it not robbery to invite our spouses, our connecting links, the men of the Omega Psi Phi fraternity, Alpha Phi Alpha fraternity, our youth parents with the Jubilarts, as well as within the schools that we partner with. We pray on tonight that you would get some beneficial information that you can share with others, and also in the event that you have not taken the correct measures for prostate cancer. We want everyone to have longevity in life. So African American men are at an increased risk of developing prostate cancer over white men and other men of color. 1 in every 6 African American men will develop prostate cancer in his lifetime. Overall, African American men are 1.8 times more likely to be diagnosed with 2.2 times more likely to die from prostate cancer than white men. African American men are also slightly more likely than white men to be diagnosed with the advanced disease. So that's why we felt it just really important that we have this webinar on this evening. So at this time, we're going to start our program, and we're going to have what we call a pre-assessment test. Now, this test, it will not be graded, and we're going to allow you to think of what you know prior to the actual presentation by the doctor that's going to give all of this excellent information. So we're going to have a pre-assessment test, and the questions will come up. We ask that you please answer them and then move on. And also, before the night is over, we have a lot of guests. We asked if you would add to the chat which organization you're actually representing. If you're a member of the Omega Psi Phi, to please put your name and put that you are with the Omega Psi Phi fraternity. So let us start this pre-test prostate cancer awareness. The first question: what are the risk factors for prostate cancer? The second question is a true or false question. Smoking is linked to prostate cancer. The next question: a diet high in dairy products and calcium can trigger prostate cancer. Fourth, prostate cancer is the most common cancer in American men. The fifth question: African American men both get and die from prostate cancer at a higher rate. At what age should men with an average risk of getting prostate cancer start being screened? 7, do all men have to be screened for prostate cancer? And the 8 and 9 are just some questions about you. So after you have answered all of your questions, please press submit. And we're going to go on with this informative webinar. First of all, we will have Link Jacqueline Chavis, who will come and provide some prostate cancer data from the Western Tidewater Health Clinic. Link Chavis.
Can we
Thank you. And
a couple more minutes to answer the questions? We still have a few more.
Okay, sure.
Just maybe 1 or 2 more minutes.
All right. So while you're answering, I told in the last webinar how breast cancer impacted me personally. And I had to say the same thing for prostate. My father-in-law had a bout with it, but we praise God. He had his surgery and he's doing well as far as with his prostate now. Also, my pastor. So I'm sure some of you may know individuals as well, but we want you to be well informed.
Okay, I'm going to close the poll.
All right. And we thank you. I see you're putting your names in chat. We have a lot of our Link sisters. We have our spouses here that are with us to let them know that we are concerned at how much we love our booze. All right, Link Chavis.
good evening and thank you. We have just a few more data points that we'd like to share with you. Pamela has shared so much about, and our sister Gloria has shared information regarding the impact of prostate cancer, particularly in the state of US, in our country. We wanted to narrow down even more, as has been mentioned, to show you the impact in our service area, which is the Western Tidewater region. So out of 35 localities in the state of Virginia, you can see where the number of incidences of prostate cancer, where it ranks, and that's 21, again, in the Western Tidewater region. And then you can see at the mortality rate stage that it ranks 33 out of 35 localities, and that's high, with 35 being the most. And so we want to, again, be sure to share information with you. This information comes from the Virginia Cancer Registry. The next slide will show you a little bit more information to go along with this. As was mentioned before, there's almost a 2 times greater risk among prostate cancer, that the incidence is among the African American community as opposed to white men. And you can also see here that was about even when we look at the number of cases diagnosed at a localized level as far as the stage of cancer for those in this service area. Black and white men are equal there. But however, again, as was mentioned, when you look at the mortality rates, there's a 2.4 times greater risk for African American men to die from this as opposed to white men. And we want to make sure that you were aware of that. Again, this is specific to our service area, Western Tidewater. Finally, if you would like more information, we are getting this data, and you'll see this on the next slide, from Centera. They've been a strong supporter for us. There's different support groups that are available through Centera. There's a number here. This webinar will be posted on YouTube if you'd like to go back and review that data, as well as review the presentation again, along to get this resource, these free resources that are available. And so we'd like to thank Centera for their support of our chapter activities. At this time, we're going to go back now and have an introduction of our wonderful speaker for tonight through, I'm going to turn it back over to you, Link Pam. Thank you.
Thank you. Yes, we're excited. We have an awesome speaker, Dr. Carthon, and we have Link Vera Campbell, who will introduce our guest speaker for this evening. And I can guarantee you, he will give us a wealth of information.
Yes, he will. Yes, he will. All right. Good evening, everyone. It is a pleasure for me to introduce tonight's presenter, Dr. Bradley Carthon. When our chapter decided to provide a prostate cancer webinar, Dr. Carthon was the first person who came to mind. As a fellow Hamptonian and former classmate who's doing extraordinary work in the area of genitourinary oncology, I felt there was no one more qualified to speak on the topic. And I thank him for agreeing to share his wealth of knowledge with us this evening. Dr. Carthon graduated from Hampton University in 1996 with honors as a biology major and chemistry minor. He went on to receive his MD and PhD degrees from Harvard Medical School and Harvard University, respectively, in 2005, where he studied the roles of cell cycle proteins in mammary gland and breast cancer development. He remained in Boston for his residency in internal medicine at the Massachusetts General Hospital. Dr. Carthon then did his medical oncology fellowship training at the University of Texas MD Anderson Cancer Hospital. While at MD Anderson, he chose to focus on genitourinary medical oncology and worked on cavelin-1 as a biomarker of prostate cancer bone metastasis. Dr. Carthon joined Winship Cancer Institute of Emory University in Atlanta in 2011. He serves as a member of the Genitourinary Oncology Group and Phase 1 Early Discovery Unit. His interest is in novel therapeutic targets and clinical trials that utilize treatment combinations for patients with prostate, bladder, testicular, and kidney cancers, as well as a broad array of solid tumors within the Winship Phase 1 group. He's the principal investigator on numerous genitourinary and Phase 1 clinical trials. He is currently Associate Professor of GU Medical Oncology, serves as Chief of Hematology Oncology at Emory Winship Midtown, and is the chair of the Winship Cancer Institute Health Disparities, Health Literacy, and Minority Accrual Committee. Dr. Carthon has served as an American Society of Clinical Oncology, ASCO, university faculty member, and as a member of the ASCO PSA Screening Task Force. He is currently a member of the ASCO Annual Meeting Education Committee for Prostate Cancer and is a member of the NRG Cooperative Group Early Phase Clinical Trial Safety Committee. That was a whole lot, everyone. Please join me in welcoming our esteemed presenter, Dr. Bradley Carthon.
Thank you, Vera.
All right.
I think you left out one of the most important things is that I'm a proud member of Alpha Phi Alpha from Gamma Iota chapter, Spring '94. But hey, we got some things to talk about otherwise. So let me just set this up here. So, I really, I'm happy to be here. I do this quite a bit in the community, not only in Atlanta, but in, different areas. And the reason why is because this is something that affects African Americans, as mentioned, at a much higher rate than other groups. And so we'll launch right into some things. We heard about the incidence for prostate cancer being the #1 cancer for males in this country. And when we talk about deaths from cancer, we see that prostate cancer is second only to lung cancer with regards to the number of deaths, with about 33,000 patients dying in 2020. And so when we talk about Georgia, you talked about the Tidewater area, but in Georgia, that comes to about 5,400 cases a year and about 1,000 men every year that will die. So not only, as you mentioned, some of the rates in Virginia, the rates in Georgia, this is across the country. African-American men are indeed suffering more than the general populace. And so when we talk about the prostate, a lot of people really don't pay a lot of attention to it until there's a problem. We don't really think much about it. It is a walnut-shaped organ that is present at the base of the bladder, and it's very important with regards to sexual function and production of seminal fluids. So generally, as gentlemen get older, the prostate enlarges. You'll notice significant others or family members may have more trips to the john, maybe don't sleep as well through the night. And that's because the prostate can actually cause blockage so that urine doesn't flow freely from the bladder. But occasionally, those symptoms might signify other problems, such as actual cancerous growth. And so we monitor with the PSA in order to detect issues with the prostate. Doesn't mean that a higher PSA level means that someone has cancer, but it is of some concern. It means that those numbers need to be followed. We talked a little bit about risk factors, including race, geography. We know that in certain countries, there's a low rate, but when those patients or people move to the Western part of the world, adopt Western diets, that their risk for prostate cancer soon approximates those from that initial area. And we know that as people become older, they become more likely to have prostate cancer. There are genetic changes that run through families. BRCA, you hear about it with breast cancer, sometimes even pancreatic cancer, but it indeed can play a role with prostate cancer. And then other factors such as diet, obesity, smoking, inflammation of the prostate are all risk factors. And so we talked a little bit about inherited gene mutations. Sometimes people can have syndromes that account for specific genetic mutations that lead to the predisposition. People can acquire genetic mutations. They can have activation of the androgen receptor. And all that is the receptor that binds to testosterone, what makes a man a man. And then, as mentioned before, environment and family history. Sometimes people may not have a genetic predisposition or gene of focus, but you know that a brother has prostate cancer, a father, an uncle, and you can see the cluster of familial cases. So as mentioned before, PSA screening helps to detect prostate cancer. Now, for the longest, there was not a PSA test. And so when men presented with cancer, it was often in the metastatic, deeply metastatic setting. But around 1990, there was the production or introduction of PSA screening, and the cases increased notably. That was because the diagnostic tool allowed for those cases to be uncovered. Over time, as screening was utilized, incidents started to fall. Now, something interesting happened. After people started testing for PSA and prostate cancer, there were many more diagnoses, but some of them were not as dangerous as one might think. Some cases might actually be able to be monitored. And so when two large studies looked at thousands and thousands of men, hundreds of thousands of men, they saw that indeed some men had prostate cancer that was indolent. It was not of a degree that it would harm them. And so there could be some risk with treating. And so there was a revision of the guidelines to say, you know what, every man should not be screened. And so you can see that the incidence dropped, but distant disease, metastatic disease, began to increase slightly. And that was directly because of the screening changes. But one of the problems is that certain groups are high risk. African Americans are high risk. Those with a family history are high risk. And we can see that despite those changes before and afterwards, there was still a lower rate of testing among African American men. And so this is not a group of patients that needs to stop with the screening, regardless of those recommendations. For high-risk groups, the recommendation for screening still exists. And so we've had to get that word out, and despite these changes, work with the African American community and high-risk groups to continue with PSA screening. Now, as mentioned before, many times men didn't have any symptoms, or they might have symptoms that could be attributed to a large prostate. But then if those things become worse, blood is in the urine, perhaps a problem with erectile function, perhaps aches and pains in the body, or at later stages, cells pressing against the spine and spinal cord where there's weakness or numbness in the pelvic area, are all signs to worry about for prostate cancer. Now, many men, we don't want that to happen. We want them to have a test early on so that we can monitor and catch things early. Now, if someone is unfortunate enough to have a diagnosis, we're not talking about PSA slightly high, but if they're actually diagnosed and have a biopsy, they may see these words, Gleason score. And what that is basically a pathologist found that by looking at multiple, many thousands of cases, you can grade prostate cancer based on how much disarray is on the slide. For example, someone with low risk prostate cancer would have Gleason 3+3 or 6 disease. That's a type of prostate cancer that could be watched and not necessarily go to surgery or radiation because there's a lower risk with that versus someone who has cells that look much more in disarray. And so if patients are diagnosed with prostate cancer, we think of their Gleason score, but we also start to think about their stage. Now, many times patients come in and they ask these questions, and I'm trying to explain it in a way so that they can get it. Now, the last time I was in Virginia, and I did spend 4 years there, but the last time I was there were dandelions all over. And I tell my patients, if there is one area in your yard, one dandelion, we can often go and remove that before it becomes the bunch of seeds and spreads. Because if it does spread, then it can set up shop. And then once again, you have a whole new batch of flowers that can repeat that cycle and spread throughout one's yard. If we're able to handle things where there is one spot, one aberrant seed, then we're able to stop things. And it's just like with cancer. If things are localized in one spot, someone has a slightly high PSA, imaging is done, and it looks like there's something in the prostate, but just the prostate, that can be addressed by a number of ways with local therapy. But as things become more and more distant and more widespread, outside of the prostate perhaps, maybe in some lymph nodes or bone, then we're talking about metastatic disease, and that's exactly what we don't want. So that is why we encourage folks to be screened so that we can catch things at the early local stage versus when that becomes metastatic. And once again, once patients are diagnosed, we look at their Gleason score, we can look at their PSA, we can look at the number of cores on the biopsies. Normally there's 12, but if we know that there are 12 out of 12 positive, that's different than 1 out of the 12 being positive. All of these things can help us place patients into risk categories. So we often will do some imaging. We'll see, what the biopsy shows, and we'll often do imaging of the chest, abdomen, and pelvis, and also bone scans. And based on that information, along with the Gleason score and PSA, we can give risk on how likely this will be a long-term problem. We even now have specialized imaging studies that can help us detect wherever disease may be, and patients that are really at an increased risk of further disease. Moreover, recently we've started to use genomics, both in the early setting and then later in the metastatic setting. And what this does is that it helps people have ease when they think about watchful waiting or just surveillance. For example, we talked about those Gleason scores, when something's Gleason 6 versus Gleason 9 or 10. We have tests where we can look at blood or either biopsies to tell us if men are at high risk for things taking off. And so that gives extra insurance that a man may be able to just watch, and then if something changes, then act upon it. It also allows us to give some insight to families on if they need further testing or workup if loved ones are affected. Now, we talked about watchful waiting for patients who have Gleason 6 disease or low Gleason disease, very low PSA. Sometimes PSA is detected, prostate cancer is detected incidentally. Those patients can be watched and monitored, because if that PSA changes or if biopsy results change, you can then safely go forward with either radiation or surgery, but that can still be done where a patient is cured. So if patients have low risk disease, or if there are other things going on that might be more dangerous to their health, patients can do watchful waiting or active surveillance. That involves periodic checks of the PSA and then acting if something changes. If indeed someone has disease that actually needs to be addressed, then prostatectomy is one of the gold standard approaches where men can have resection of the prostate and lymph nodes, and they try to preserve the nerves around the prostate. That allows for patients to have erectile function and for patients to have continence, because after surgery, it's not uncommon. Actually, it's quite expected for many men to have some problems with that. Sometimes that erectile function or continence recovers, other times not as much, but patients often will have a nerve-sparing prostatectomy if possible in order to help with that. And this can actually be done with robots. They many times don't have to do a full open resection. They can use Da Vinci robots or other robots to do these types of procedures. Now, we talk about African Americans and how do we fare? Well, we know that even if we're talking about the gold standard treatment, SEER analysis, which looks at patients based on public health data across the country, looked at 26,000 people. And we can see that African Americans were less likely to undergo one of the gold standard treatments. And this is over the course of about 20 years. But as time has gone on, even though there are some improvements, there's still been that disparity. So we want to make sure that patients receive the best treatments and the best screening approaches. If someone is not able to do surgery, many times, especially those with higher risk, can do radiation plus or minus some hormone therapy to take away testosterone. That allows for extra killing power to kill prostate cancer cells in the prostate, as well as those that might have slipped outside of the prostate into lymph nodes. And similarly, this is just data looking at about 600 patients to see what percentage of Black patients and white patients had the benchmarks with regards to prostate radiation. And we can see differences in the amount of radiation, the treatment planning of radiation, and even the inclusion of lymph nodes where dangerous disease could escape to. So once again, we want to make sure that patients receive the best treatment, but regardless of whether it's surgery or radiation, at times that treatment has been subpar. We know that there are some ways to improve that, and we'll talk about that in a little bit. And then occasionally, patients are not candidates for surgery or radiation, and there might only be a single focus in the prostate. Those can actually be frozen. They can actually use thermal energy with high intensity ultrasound. Those are not yet gold standard, but for some patients, they are indeed options. And we usually encourage folks to talk with doctors in a multidisciplinary format where everybody's there to discuss the pros and cons. But there are many treatment options for localized disease. And we want to keep it at localized disease because we can see that as patients have developed distant disease, and then when we look at all stages, including metastases, African Americans have a slightly lower 5% 5-year survival. Now, that doesn't seem like a whole lot, but if you think of the many, many thousands of men each year that develop prostate cancer, those few percentage points leads to some of the numbers that you saw with regards to disparities. If someone has local therapy, many times their PSA will drop down to almost undetectable levels. That's great. That means the prostate cells that make PSA have been destroyed or handled. But many times that PSA can start to rise again, indicating that there are cells that may be returning or growing even after radiation or surgery. And so we try to personalize the approach. Every approach is different depending on the patient. Some patients may have a very, very low PSA and they can be observed. Other patients may have risk factors on their surgical specimens that would suggest that radiation or even radiation plus hormone therapy after surgery are indeed warranted. And for some patients, they may need to have testosterone in their body reduced because they may have such high risk factors. These are all things that can take place after someone has had localized therapy in order to try and enact cure. So when we talk about localized prostate cancer screening, is indeed recommended for most groups, definitely for high-risk patients like African Americans. There's now the risk of a discussion, not necessarily the risk, but the recommendation for discussion. Because, for example, say someone's 90 years old with other health problems, it's quite unlikely in that instance that prostate cancer might be their risk of demise. But for someone who's young with a family history, of course, that's a very high-risk patient. who needs that screening process. We're biased. We encourage all men to have that screening and to talk about the risk and benefits of that. Some patients can do watchful waiting or surveillance if they have a low-risk disease. And prostatectomy is a gold standard approach for those with intermediate risk, especially young patients. Patients who may have other medical problems and couldn't necessarily handle surgery, or those who have disease that may be outside of the prostate are prime candidates for radiation plus or minus some hormone therapy. And if PSA arises after initial treatment, we still think of each patient in a way in which we can enact cure. Now, what about metastatic disease? This is an old slide, and this is often what happens. Folks or older gentlemen would have aches and pains, and it's just arthritis, and pass it off and don't think about it, but go in because the pain is so bad, and a bone scan or x-rays would just show these little black spots, which would be cancer throughout the bone. We don't want to see that anymore, and unfortunately we do. So what do we do when this happens? We have to take away testosterone. Now, no one likes to do that, but we know that these cells grow and feed on testosterone. Most of the testosterone in the body is produced in the testes, but it can also be produced in the adrenal glands and even in the prostate cancer cells themselves. So trying to stop the production in all of those areas is one of the prime ways in which we treat prostate cancer. It's not without side effects. Men can have weight gain, decrease in their bone density, increased risk of diabetes and heart disease, and even thought changes and psychological changes. Some of the things that our female counterparts complain of or say when they go through menopause can be some of the same type of symptoms: hot flashes, night sweat, things like that, in addition to these medical complications that men have when they undergo androgen deprivation treatment to reduce testosterone. Now, we do not have time to go through all of the things that we use with patients, but this one slide really is meant to show what is the toolbox in prostate cancer. And all of these things have come forth over the last 20 years, tremendous amounts of progress, whereby we're making strides in how men survive from prostate cancer, even in the metastatic state. But the key point is to have access to all of these tools and to have access for clinical trials. We can talk a bit about that. We also have new imaging. This is one of those specialized PET scans I talked about, where if there's PSA that's rising, we can have these tests that look at the sites of PSA production to determine where exactly the PSA is coming from. So once again, even when something is metastatic, we're often able to pinpoint where it's coming from to see if there are additional things that can be done to help cure these patients. And even more importantly, we now are using genomics in the metastatic setting. Patients present with metastatic disease. We have our standard medicines in the toolbox. We can now predict which medicines will work for each patient by using just a little bit of blood and checking for cancer cells in that blood and for DNA from those cancer cells in that blood to let us know if certain medicines may work better than others, or if certain medicines are not going to really work at all. And a key point in progress has been trial participation. There's a lot of distrust. We can see here that prostate cancer patients are 15% African American across the US, but in certain pharmaceutical sponsored trials, only about 4% of those patients are African American. And then in consortium studies with academic universities, only about 12% of those patients are African American. There's a gap and we need further enrollment. Of course, there's distrust, and rightly so, but part of what we're doing now is trying to enhance participation in trials so that new medicines reflect the biology of us. We know that through focus groups, lack of understanding, distrust of healthcare systems, unfavorable attitudes towards research, with the Tuskegee experiments and the Henrietta Lacks story. These are things that are still very prevalent when people think of research. And so we're working to try and improve upon this at our academic centers. So just to summarize for prostate cancer, be aware of the signs and symptoms. Screening discussions need to take place to discuss risk versus benefit. We encourage patients to see academic centers where they can have multidisciplinary input early on, and to take advantage of things like next generation imaging that is becoming more and more precise. We have a toolbox that is full of medicines for metastatic disease And those medicines are often being utilized earlier and earlier with better results with regards to overall survival. And we're using genomic analyses early at the time of diagnosis, as well as at the time of metastases and disease progression. And clinical trials with diverse patient populations are key. I leave you with a few recommendations from the American Cancer Society. So many of our cases of cancer in this country are related to environment and health lifestyles, approximately 65% of those. So peruse these values and different tidbits of information. And most importantly, have the regular checkpoints, checkups, and cancer screening to make a difference in our cancer outcomes in the U.S. Thank you very much for having me. And at this point, I'll try to answer any questions if they exist.
Thank you so much for that wealth of information. I ask if you will put any questions in the chat, and I will ask the questions and allow Dr. Carthon to answer the questions. He gave us a wealth of information, so please feel free to ask your questions at this time. I'm going to give you some time to ask them in the chat, and I will make sure that he will have the opportunity to respond to your question. Okay, so we have a question. Our first question is proton therapy versus radiation therapy.
And that's an excellent question. And if I'm correct, I think that would mean if a patient's going to do, radiation therapy for their treatment, is there a difference between proton therapy and standard radiation therapy? You know, radiation just comes in different energy molecules or forms. Protons are a type, and the other type are photons. And all that means is the same energy travels through skin, tissue, and body organs in different ways. You know, the outcomes are actually similar, but there is some advantage to proton therapy as you're trying to spare the surrounding tissue. For example, standard external beam is treating the prostate and everything in the pelvis. For that reason, men often have side effects with erectile dysfunction, diarrhea. They can even have radiation proctitis, that's bleeding from the colon because it's right behind the prostate. Proton therapy allows for things to be much more precise and can actually penetrate into tumors, but not penetrate through. So depending on each patient, there may be some advantage to the side effect profile with regards to protons. The survival thus far is very similar, but the side effect profiles can differ. And so patients, we encourage them to discuss that with their radiation doctors about which might be best for their case.
Okay, Dr. Carthon, we have another question for you. What are the most promising treatments on the horizon for this dreadful disease?
Well, one of the things that I'm actually really excited about are things that are based on a person's genetic profile. For example, there are medicines that actually cross diseases, meaning if someone has a mutation, remember we talked about BRCA. I don't know, I think, people doing your mammograms, you might have heard of the BRCA gene where patients may have prophylactic mastectomies, and that actually exists in prostate cancer. So if patients have a family history where mom, aunt, sister, breast cancer from BRCA, the men can be at risk for breast cancer, but also prostate. And so there are medicines that treat that genetic mutation, despite whether it's pancreatic or breast or prostate or bladder. So genetic and genomic profiling is very exciting because it allows for specific matching, meaning we're not guessing as much. We're actually able to see if that particular medicine or if immunotherapy works. Interestingly, a lot of these studies with all those things in the toolbox I showed you, when African Americans are placed in a controlled environment, meaning people aren't having to take a different route to get to the doctor. They're not having to drive from Western Virginia to get to the Tidewater area or to a doctor. When you eliminate those things in environments such as a clinical trial or such as the VA, where everything is equal, African Americans are doing actually very well with the number of those agents in the toolbox. And so sometimes that's actually thought that the testosterone axis is stronger, and so blocking that can have even more benefit. So to summarize, the genetic testing that allows us to pinpoint medicines, and then all of them are exciting to me, but largely because once we know patients can receive treatments, African-American patients are doing just as well, if not better, than many of their counterparts.
All right, we have a few more questions. Are there any treatments that are more effective in African Americans, or are there any that should be avoided?
Well, similarly, we were talking about some of those trials and things. We actually know that some of the medicines that block testosterone work extraordinarily well with African American patients. There's proposed that there are genetic factors that process testosterone that allow for those medicines to be more active in African Americans. As far as ones that would be avoided, I wouldn't say as a group there's any that needs to be avoided, but if patients present with the disease, we can send a profile and we can know specifically for each patient, this one may not work for Mr. Jones. This one may work for Mr. Thomas. This one may not work for Mr. Smith. So being involved with, discussing genomic profiling and knowing about it, I think is very important because it allows the guessing to be minimized.
All right. And this kind of goes along with our next question. For preventive care, what conversation would you recommend to have with your doctor?
Yeah, right. I think the couple of questions are, very similar. So believe it or not, my primary care doctor, he never mentioned prostate cancer. And I mean, he knew I was a prostate cancer specialist. I guess he was intimidated or whatnot. So finally, after about 2 times, I said, I'm 43 years old. You haven't mentioned prostate cancer to me once. And he's like, oh, well, I figured you would tell me if you need it. I think the bottom line is we need to realize there's high risk. I think many people know this. And we need to ask that question, hey, doc, I understand I'm in a high risk category. Can we talk about prostate cancer screening? If something that you're not comfortable asking that question, then I don't know, maybe that's not the right primary care doc for you. But I think knowing that we're in a high risk group and mentioning that as part of your annual is important. Now, many times the question of how often do you check comes up. If someone checks and has a normal PSA, that can buy them some years. But if someone has a modest PSA and in the next year you see it's changing, then following that on an annual basis or even shorter periods are indeed warranted. And sometimes if there's a change over a few years, then referral to a urologist to further assess makes sense.
All right, and that kind of answered the question, our next question about African American males being tested with every annual physical exam for 40 and older. So we thank you so much. Are there any other questions? All right, well, if you have questions.
And if I could just say one last thing.
Sure.
A lot of men really hesitate to have prostate checks because they think that it involves a physical exam. And I tell them, no, we can actually start with a blood test. If something's abnormal, then a physical exam might be necessary. But I think one of the big misconceptions is, oh, I go to the doctor, they're going to, do something horrible. And that's just not the case. We can start with a blood test. And if there needs to be more, then that can be done.
All right. Well, thank you so much, Dr. Carthon, for all of your wealth of information, being able to answer our questions. We still may have some questions later. We know this webinar is supposed to actually be over at 8, but we're getting such a wealth of information. We ask that you just stay with us for a little while longer because we have another guest presenter that's going to come about talking about caregivers. And we know a lot of times caregivers go through so much because they're providing care. They neglect themselves, and we know self-care is so very important. So at this time, we're going to go over the important role caregivers have and the importance of self-care. Jackie Chavis will introduce our speaker for this part of our webinar.
Thank you. And as we get ready to move into the role that a support person plays, as the title of our webinar tonight says, taking care of you for us, our loved ones, our spouses, our sons, and others. And so we need to know what we can do to better support you through this process if it becomes necessary. A dear friend of mine, Mrs. Evelyn Lee, is going to be joining us with the remaining few minutes we have in our webinar. She and her husband, Jim, just completed his therapy with proton therapy at Hampton University. So he has taken this journey and she has been along his side, on his side along the way. Mrs. Lee is Associate Minister of Congregational Care and Director of Renew Counseling at First Baptist Church, the historic First Baptist Church in Norfolk, where Reverend Dr. Robert G. Murray is the senior pastor. She's also a retired hospice chaplain with Chesapeake Regional Healthcare. She is a retired school counselor with Norfolk Public Schools. She is a devoted wife, mother, and friend. And I can attest to the fact that she has been by Jim's side along this way. As I see, we also have one of our Link sisters whose husband is a cancer survivor and may be able to share information as well with us. So Mrs. Lee, thank you for joining us. And we'd like to know from you how we can support those who are on this journey. You're on mute.
Hi, everybody can hear me?
Yes.
Yes, okay. Well, thank you for having me. And I'll start by saying in January of this year, my husband was officially diagnosed with Alzheimer's disease. And then I say officially because the year before he had seen a neurologist and didn't complete all of the tests. And so officially was not diagnosed. But anyway, so that was January. February, he received the diagnosis of prostate cancer. So with my background of being a clinical chaplain, along with my type A personality, and of course, my faith shaped how I went about this journey, caring for him and advocating for him. And so I asked my husband today, as I was, making some notes, what kind of caregiver am I? And he said, wonderful. And then I said, well, how come? And he said, well, because, you're on top of everything. You do everything that I need to be done. And I said, well, what else? So he said, well, sometimes you can be like a drill sergeant, and sometimes you are harsh in the way that you say things. And so I said, well, I know you've said that to me in general, but also during this journey, he mentioned that as well. So as I think about what we've been through this year, like I said, with my personality of being organized, taking charge, that's what I did for him. And primarily, I had to do it because of the memory issues. He's still high functioning, but definitely has memory loss. So I took it upon myself to advocate for him. The journey was complicated because of the pandemic, and the timing of his diagnosis was at the height of our shutdown here in Hampton Roads. So as you heard the doctor explain the different types of tests that have to be done, that was what we were trying to get done in the midst of the pandemic. So needless to say, it was overwhelming. And I had to push to get his appointments that he needed for his scans and for all of the things that he needed to do to prepare for the proton treatment. We were blessed that after doing the research of the different types of treatment, we opted for proton. Initially, the insurance wouldn't pay for it, but just God performed a miracle and they covered it. So the only thing we had to pay was a copay and drive to Hampton 45 minutes one way every day for 44 treatments, Monday through Friday. So basically, I just assumed the role as a fierce advocate, working in the healthcare system, being in charge of congregational care at our church. I've administered a few cancer awareness grants for our church. I knew what could happen. I knew what I didn't want to happen to him. And so I just had to do what I had to do. Now, that was positive for him. Like he said, I stayed on top of everything. But for me, I crashed and burned in the counseling terms around March, probably the end of March, the beginning of April. I was burned out. I was depressed. And also, it wasn't just the caring for him and negotiating the system, but it was complicated by the need to social distance, to be shut in. And I'm more of a social person. I interact with people. That kind of drives me. And none of that was happening. And so I'm not ashamed to seek and use my resources. So I did therapy for a few sessions. I went to my primary doctor and she gave me some medication to, help me with the depression. So I would say that our personalities impact or can impact how we caregive. As I mentioned, I'm more of type A, I got to be in control, et cetera, et cetera. But the downside of that is if I don't take care of myself, I will be depressed and burned out. So what I've started doing is I walk every morning, 3 miles, 5 days a week with a close friend. I've started getting a massage once a month. I have my own bubble in terms of social distancing. So during the summer, I went to the beach pretty much every day. I was blessed. A friend lives on the beach. So I had to start taking care of myself. I also am trying to make an effort to not be harsh when I talk to my husband, but quite honestly, sometimes I am angry. Sometimes I am frustrated. I'm angry. I'm angry because he can't remember things. And it's hard to accept that he can't. So I'm angry, not with him so much, but just with the phenomenon of memory loss. It's almost like grieving. You go through stages, and one of the stages is that you're angry. Sometimes you're angry at the person who died, you're angry at, whatever, the disease. So yeah, sometimes I am angry. And as you know, the people who are closest to us often are the recipients of our feelings, whether they're good or negative. So communication is key. We just have to talk about this as best we can. I need to not always do things, but empower him to do what he can do instead of my trying to protect him and just taking charge all the time. So that's something that I have to work on. The other suggestion I do have is for the women. It may seem intrusive, but a lot of our men don't like to get preventive tests done. Prostate examinations is an example. The doctor mentioned that, yes, you can have a blood test, but sometimes it requires a different type of test. And I told one of our church members recently, he said he didn't want to get poked. And I said, well, consider this. You can get poked once a year, or you can get poked every day for 44 sessions. So which one do you want? And that's if he, you know, had proton. So in this case with my husband, he was diagnosed because I said to the primary doctor, it's time for his prostate exam. And she says, you're right. So that's what I mean about being proactive and being an advocate. And you know your husbands or loved ones in your family, you know how best to deal with them. But I know, as I said, from working in the healthcare system, that so many of the diseases and illnesses that I witnessed and patients that I had in hospice could be prevented if we would just get screenings and stay on top of different medical illnesses and learn as much as we can. So I would encourage you, if you have to take charge, then so be it, because a lot of times they just won't do it. And so I'm grateful. My husband was grateful that, you know, he didn't like it in the exams once a year or whatever it is, but, you know, he would do it. So I think that's all. I know the time is limited. I think I covered pretty much. And I wanted to say another thing. As Jackie mentioned, I am a minister. And during that height of the pandemic, when I was pushing, calling to make appointments every day and not getting the answer or getting wrong information, if I had to do it all over again, I would pray every time I made the call. But because I was so consumed with getting him what he needed, I didn't do it. And so I was uptight. By the time I got off the phone, I was just frazzled with these people. And so my faith is really, really strong. I'm not scared. I don't fear what's to come. I've worked in hospice. I know what it can look like, but I'm not claiming that. But on the other hand, I'm not ignoring. I'm not in denial. I'm just living every day. And I'm thankful that I'm here to care for my husband or to assist him, because he can still do, you know, a lot of things for himself. So that's about it. That's my story for the last almost a year. And he's doing well. He will have to be monitored every 3 months. And, you know, we just thank the Lord that he was able to get the proton. As the doctor mentioned, he was just blessed. No side effects, none. Absolutely none.
Wow, thank you so much, Reverend Lee. I give you a shout out for all you are doing for your husband, all you will do for your husband, and most importantly, for being persistent, because a lot of times we miss our blessings and we miss actually what we need to have for our spouses or others that we have to take care of, because we aren't persistent. When someone says no, our door closes, we just don't go ahead on and grab it at what we have faith and what we need to have. Thank you so much. I will keep you and your husband in my prayers in this. I know being a caregiver is not easy. And I'm so glad you started with your self-care, going to the beach and your massages, but we will definitely keep you in our prayers. Are there any questions at this time on the caregiver aspect? Any questions? Okay, I do not see any questions. Again, we ask that you stay with us. We only have a few more items on our agenda for this evening, but thank you so much, Reverend Lee. Thank you. So you all have heard a wealth of information from Dr. Carthon, and I know prior to his message, his brief message, you actually completed a pre-assessment test. We're going to move on at this time, and now we're going to have a post-assessment. These are the same questions, but we want to see if your knowledge has increased. So the questions are up on the screen, and we ask that you please answer the questions. The first question, what are the risk factors for prostate cancer? Smoking is linked to prostate cancer. A diet high in dairy products and calcium can trigger prostate cancer. Prostate cancer is the most common cancer in all American men. African American men both get and die from prostate cancer at a higher rate. At what age should men with an average risk of getting prostate cancer start being screened? Do all men have to be screened for prostate cancer? Okay, so for the next questions, I mean, you can just answer them so that we can submit. And then click submit, and then we're going to go over the answers. All right, are we ready for our answers or to see how we did on our post-assessment test?
A few more minutes.
Okay.
We're at 64%.
All right.
Okay, I think we're ready.
Okay. And we thank you for participating in these assessments. All right, so the first question, all of the above, 100%, awesome, awesome. Okay, question 2, smoking is linked to prostate cancer. All right, so the answer to that is actually false. Okay. Question 3, a diet high in dairy products and calcium can trigger prostate cancer. That is true. 4, prostate cancer is the most common cancer in all American men. That answer is false. And the trick to that is all American men. All right, our next question, African American men both get and die from prostate cancer at a higher rate. All right, 100% true. All right, our next question. At what age should men with an average risk of getting prostate cancer start being screened? And the answer to that question is 50. 7, do all men have to be screened for prostate cancer? And the answer to that is no. All right. We thank you for participating. And we're going to move on at this time and have some remarks from our president, Link Dewan Hoffler Foster. So if you give us a few more minutes, we will be finished.
Yes. Members of Alpha Iota Omega chapter of Omega Psi Phi, Alpha Phi Alpha fraternity, and all Divine Nine members, East End Baptist Church, Jubilant Arts, the student and the parents, as well as Reverend Faison, the pastor of East End Baptist Church, Booker T Elementary parents, connecting links, and special persons connected with the links, family and friends of all the above. Good evening. Several years ago, this program was partnered between, the links partnered with Omega Psi Phi, and we did that for several years, and it was at the hospital, and we look forward to this evening. And it was fun and educational. The fun part was that, you know how you say you were drugged to church? Some of the men were drugged to the screen, and the wives, girlfriends, and everything else were calling and ushering them down there. We had to tell them we would make sure they stayed for the exam. But it was a fun evening as well as educational. And I was thinking of that, Reverend Lee, when you made that reference in your presentation. Dr. Carthon, am I pronouncing his name correct?
Carthon.
Carthon, okay. Thank you so very, very much for continuing the educational process of prostate cancer, as well as giving the light side of something that can be very horrible. And you answered some questions, as well as giving us new information. This effort is really true realization of a team working to achieve the dream. At Jackie Chavis, Gloria Sproul, and Pamela Jones-Watford, thank you for everything you have done to make sure you covered all of the bases. And they know, well, Gloria doesn't call me late because Gloria goes to bed early, but Pam and Jack and the others know, they can call me late. Don't do it early in the morning. But at any rate, they make sure that they have everything, and I am where I'm supposed to be. And we have a base of people and organizations we can reach out to with our future webinars. Is that right, Jackie?
Yes.
And Pam, yes, all of it. And yes. I see two of Jackie's brothers, made them come. And I think Newport News and Atlantic, I'm going to say Atlantic City, New Jersey. I'm just going to say that because I forgot where he's from. I see Archie and others. I know I shouldn't have done that because I've missed some other relatives up here. I'm not talking about the connecting links, because they are given, and the organizations. But I trust you will join us, and they will keep you abreast of all of the things that we are doing. And in view of the time, I think I'm going to stop. And Pam is shaking her head, and Gloria and Jackie as well. But thank you again for taking the time out of your evening to join us. And I turn it back over to Pamela.
All right. Thank you to our president, Link Dewan Hoffler Foster. And I just have to get a big shout out to Dr. Carthon, who gave us a wealth of information. Thank you, thank you, thank you. We will leave this webinar much knowledgeable. Thank you so much. We would like to also thank Link Vera for connecting us. We're thanking her for connecting us with our speaker because he gladly accepted the invitation, and we're just so thankful. And even while I'm thanking her for that, we thank her for her technology, all of our technical assistants with this webinar, as well as others on the ICC committee. Now to Reverend Evelyn Lee.
I'm sorry, Vera. I'm sorry, I forgot.
I would like to thank you. I'd like to let you know I'm praying for you. I want to give you so much encouragement. You remind me so much of my mother-in-law. When I say that, she is an elder in the church. My father-in-law, he's gone through prostate cancer and right now going through dementia. And when I say she holds his hand, so I am just praying for you, but thank you for all you've done for your husband, and then importantly, all that you're going to do for you're doing for yourself. I would like to say to my former neighbor, Andrea Tillery Wilkins, and her son, Wesley. Thank you, Wesley, for your talent, your gift of playing. We thoroughly enjoyed your music. To my friend, Cecilia, I know she was up here earlier. If she's still up here, thank you so much for just sharing and teaching, being able to teach our children the gift of music, because everything that God writes is a song, and music is just so awesome. To the brothers of Alpha Iota Omega Psi Phi Fraternity Incorporated, in which my father was a life member for years. Thank you so much for joining us. To the brothers of Alpha Phi Alpha, thank you for joining us. For our schools that we partner with, thank you so much for being a part of this webinar. We hope and pray that you were blessed with this information on this evening. To our connecting links and our other links family, we thank you also, because you have to put up with us in all that we do for LinkedIn, but we wanted to share this information with you on this evening. And to our link sisters, we thank you as well. Thank you for joining us. Again, we are planning a series of webinars. Last month, we had an awesome inspirational webinar on breast cancer. So more is to come. Thank you so much for joining us. We pray that you have a restful evening. We do acknowledge there are other ministers up here. I know Link Dewan also already acknowledged Reverend Dr. Faison of East End. I saw Elder Trevon Boone is up here. Reverend Lee, my husband, Reverend Watford, any other ministers. I'm going to do my protocol. So thank you so much. We appreciate you, and we look forward to you joining us in our next webinar. This will be on YouTube, so that you can, this will be on YouTube.
Before we end, I'm sorry, we have neglected the Kappas who are also on our webinars tonight. So to those brothers, thank you for joining us as well. One is joining from New Jersey, and we have another local. There may be others who didn't put that in the chat, but thank you also for representing.
Thank you, Diamond Man.
I didn't know that.
All right, we're reaching for the diamond. We acknowledge you as well. Thank you so much for joining us. And look on YouTube if you want to go back and get this information. We actually have our breast cancer webinar, which is on our YouTube channel. We ask that you subscribe to the links YouTube channel. And also now we will have this up here at a little later time. Thank you again to our technology committee for all of your assistance. And we look forward to seeing you again. We pray that you rest well and have a good night.
Thank you.
Thank you.
You're doing for yourself. I would like to say to my former neighbor, Andrea Tillery Wilkins, and her son, Wesley. Thank you, Wesley, for your talent, your gift of playing. We thoroughly enjoyed your music. To my friend Cecilia, I know she was up here earlier. If she's still up here, thank you so much for just sharing and teaching, being able to teach our children the gift of music, because everything that God writes is a song, and music is just so awesome. To the brothers of Alpha Iota Omega Psi Phi Fraternity Incorporated, in which my father was a life member for years. Thank you so much for joining us. To the brothers of Alpha Phi Alpha, thank you for joining us. For our schools that we partner with, Thank you so much for being a part of this webinar. We hope and pray that you were blessed with this information on this evening. To our connecting links and our other links family, we thank you also because you have to put up with us in all that we do for LinkedIn, but we wanted to share this information with you on this evening. And to our link sisters, we thank you as well. Thank you for joining us. Again, we are planning a series of webinars. Last month, we had an awesome inspirational webinar on breast cancer. So more is to come. Thank you so much for joining us. We pray that you have a restful evening. We do acknowledge there are other ministers up here. I know Link Dewan also already acknowledged Reverend Dr. Faison of East End. I saw Elder Trevon Boone is up here. Reverend Lee, my husband, Reverend Watford, any other ministers. I'm gonna do my protocol. So thank you so much. We appreciate you and we look forward to you joining us in our next webinar. This will be on YouTube so that you, this will be on YouTube.
Before we end, I'm sorry, we have neglected the Kappas who are also on our webinars tonight. So to those brothers, thank you for joining us as well. One is joining from New Jersey and we have another local. There may be others who didn't put that in the chat, but thank you also for representing.
Thank you, Diamond Man.
I didn't know that.
All right, we're reaching for the diamond. We acknowledge you as well. Thank you so much for joining us. And look on YouTube if you want to go back and get this information. We actually have our breast cancer webinar, which is on our YouTube channel. We ask that you subscribe to the links YouTube channel. And also now we will have this up here at a little later time. Thank you again to our technology committee for all of your assistance. And we look forward to seeing you again. We pray that you rest well and have a good night.
Thank you.
Thank you.